this early breast cancer as well. The next 90 minutes, I can promise you, is going to be uh, an academic feast, a lot of discussions, and through the discussions, we intend to discuss the burning issues and the evolving issues, some of them right at the heart of the clinical development and the pushing the paradigm, the CDK4/6 inhibitors, they seem to be all over the place now. And very interestingly, you would hear about the data of palbociclib even in the HER positive uh, disease. And after the 6 presentations on these interesting topics, we have an equally interesting panel discussion to be led by Dr. Suman Mittal from Raipur. And I do hope and trust that these webinars, month on month, are adding value to our knowledge, advancing the knowledge, and helping us treat our patients better. At the very outset, let me thank Mice Ideas for piloting the project and bringing these webinars alive with participation from all over the world. And the numbers are impressive. They are only getting better. And also thank Indian Oncology Foundation for providing this platform month after month. I would be failing in my duty if I don't thank Samarth Pharma and Mr. Om Mishra. In his personal capacity, he's been very enthusiastic and also keeping the agenda very neutral, very academic, and not be driven by entirely by the commercial aspects of it. Thank you, Om, once again and again, I would say. Over the last many years, you've been supporting these endeavors. With that, I pass on the proceedings back to Dr. Khushi Singh, who would be moderating this session and inviting the speakers from here on. Over to you, Dr. Khushi.
Thank you so much, Dr. Ashok Vatsal, for a great beginning of the advancing care in the metastatic breast cancer. So now let's begin with our first sessions of the program, for which we have Dr. Rajat Charan, sir. And sir is a senior consultant. Sir is a senior consultant and Department of Medical Oncology, Narayana Hospital, Narana Super Speciality Hospital, Delhi. And sir is going to speak on superiority randomized control trial evaluating the effect of symptoms monitoring in metastatic breast cancer patients. Over to you, sir.
So thank you, sir, and thank you so much. So I would like to share my screen. So is my screen visible?
Yes, sir, it's visible.
Okay. So this is an interesting study which was presented in San Antonio last year. It is basically based on supportive care and quality of life of the patient. It's a superiority randomized controlled trial evaluating the effect of symptom monitoring in metastatic breast cancer patient. So we do understand that quality of life really matters in managing metastatic breast cancer patients. So this study was designed in Germany and it is known as the PRO-B study. The trial design was initially published in 2021. So this presentation will detail a randomized control trial examining the impact of patient-reported outcomes, monitoring with the automated alerts in metastatic breast cancer patients, and we'll discuss the study design, methodology, results, and implications for future clinical practice. So background of this study is that we do understand that metastatic breast cancer affects a significant proportion of patients, and 30% patient experience distant mets, and this signifies a shift in treatment focus from cure to managing symptoms. So not only prolonging survival, but also to improve the quality of life of our patients. So we do have certain data. In fact, there are 2 studies which have previously shown that utilizing the PROs can play a crucial role in optimizing symptom management and improving quality of life, and that has translated into improved overall survival for breast cancer patients. So, by using PROs into clinical practice, healthcare providers can gain valuable insights into patient experience so that more personalized intervention can be offered. So this study, that is the PRO-B study, was a multi-center study. It was conducted in 52 centers across Germany. It was a superiority randomized control trial designed to rigorously evaluate the effectiveness of PRO monitoring with automated alerts in advanced breast cancer patients within the German healthcare system. So the it was basically a mobile use of smartphone where a software known as the Onco box was used, and a weekly alert was offered to the patient in the experimental arm. So total of 924 patients were taken in this study across 52 centers from May 21 to June 23. And this board participation ensured a diverse and representative sample population. So the intervention arm was given weekly PRO's questionnaire through, and the reminder was sent through a smartphone. So these questionnaire utilize the URTC CAT item banks QLQC 30 domains, which focused on five main component like sorry physical function, role function, emotional function, cognitive function, social function, and nine symptom scales like fatigue, nausea, pain, dyspnea, insomnia, appetite loss, constipation, diarrhea, and financial difficulties. So these focused on key symptoms domain which are frequently encountered in advanced breast cancer patients. So these patients were given automated system alerts, and this system was designed so that patient can receive alert to the treating centers when a PRO questionnaire values indicated a significant deterioration in symptom severity, and the alerts were prompted if there was no response. Follow-up was given after 48 hours to the respective center to address the identified symptoms and ensure timely intervention. So the results was that a total of 909 patients, 456 in the intervention arm, they were included in the analysis. And the median age of the population was 50.7 in the intervention group and 51.1 in the control group. The majority of the patients were hormone receptor positive, and the patients were randomized on the basis of hormone receptor positivity and hormone receptor negativity, and the breast cancer center and types of remote mets. And in terms of performance status, the intervention arm had a slightly higher proportion of patients with a performance status of 0, 21.5 versus 18.5%. And the control arm had a higher proportion of patients with performance status of ECOG 1, 53.7 versus 57.8. Median duration of follow was 64 in the intervention arm and 52 weeks for the control arm. So the outcomes was that the fatigue T scores, you can see that in the intervention arm, that is the PRO arm, as compared to the baseline, there was an improvement in the fatigue T score after 6 months. So that was the primary endpoint of this study, that is fatigue T score at 6 months of at the end of 6 months. So it was better in the intervention arm and it was statistically significant, whereas there was no difference in the fatigue T score in the control arm. And this also probably translated into a 12-month OS rate favoring the intervention arm, 88% versus 85%. Again, that was statistically significant. So the quality of life and the PF scores, they were better in the intervention arm as compared to control arm. So the conclusions of this study is that weekly PRO monitoring with automated alerts demonstrably improved symptom control in metastatic breast cancer patients. This suggests that incorporating PROs into clinical practice can effectively address patient-reported concerns and enhance patient care. And the subgroup-specific analysis revealed a significant improvement in the OS also in the intervention arm. So while further investigation is needed, these findings underscore the potential of PRO monitoring to positively influence patient outcomes. So really sorry. So this study basically showed that PROs, by using a simple mobile app, can potentially improve the quality of life and fatigue score of our patient. So I think this is actually a relevant study for our set of patients. But I think the problem with this study is that the number is still small. And I think in most of the private hospitals, we do tend to follow up our patients and manage them through phone to some extent. And these PRO symptoms can only be done for those symptoms which are not serious. For acute toxicity, we need a better communication between the patient, but still there is something, for less addressed adverse event and symptoms of breast cancer patients like fatigue. So if this can be managed through
Sorry to interrupt you,
this
sir,
option,
but we are not able to see your slides.
so there is no slide. So
Okay, sir. Perfect.
so definitely it's a practice changing study. So with this, I would like to conclude. Thank you.
Thank you so much, sir, for an informative talk. Moving ahead with our agenda. So for that, let's start with second talk. For that, we have Dr. Jehan Dawa, and sir is a senior consultant department of medical oncology, and sir is going to speak on associations between the risk reducing surgeries and survival in young BRCA carries with breast cancer result from an international cohort study. Over to you, sir.
Thank you, Dr. Kushik. I request the organizers to please share my slide deck.
Yeah, sure, sir. We will share it.
So, good evening, everyone. Sorry, I have to make this, have to do this presentation while traveling. There's a sudden urgent plan which I have to attend to. So, kindly excuse me if there are some connection drops. So, I'm Dr. Jayan. I'm a medical oncologist in Mumbai at Jaslok, and today I'll be talking about the association between risk reducing surgeries and survival in young BRCA carriers with breast cancer. And these are the results from an international large cohort study. So we all are aware about BRCA carriers being in a higher risk of second malignancies or say higher risk of breast and ovarian cancers. But the interesting part about the study is that they took in patients who had already been diagnosed with breast cancer. And if you look at literature retrospectively, there is no survival benefit for a mastectomy, risk reducing mastectomy. Of course, the oophorectomy has shown an overall survival in the past, but this study focused on patients who had a past history or a diagnosis of breast cancer already. Why this study is important, according to me? So, what I see in my daily practice is, ladies who have already been my patients for breast cancer, have undergone a mastectomy, received chemo, radiation, or whatever treatment as a part of their protocol. And then, if they turn out to be BRCA positive, convincing them for a risk reduction surgery is always been difficult. They're not willing. They feel that we don't want to go in for a second surgery. So this data from this large study is quite convincing. It will help us, I feel, amplify our counseling ability and convince patients. So let's jump into the study. So patients who had a germline pathogenic or a likely pathogenic variant of BRCA1, BRCA2, and these patients are known to have a significantly increased cancer risk. And there's a widespread recommendation of risk reduction surgeries. A risk reducing salpingo-oophorectomy has known to have an overall survival benefit, and a bilateral risk reducing mastectomy also reduces the risk of developing breast cancer, but there is no proven benefit. There is no proven overall survival benefit. Next slide, please. So, existing evidence says that there is limited data available for a risk reducing salpingo-oophorectomy or a risk reducing mastectomy. And the current study objective is to investigate the association between a risk-reducing mastectomy and a risk-reducing salpingo-oophorectomy with survival outcomes in one of the largest global cohorts of young BRCA carriers with breast cancer. Next slide. So this was the BRCA BCY collaboration study. So it is the breast cancer young collaboration, breast cancer in young women collaboration. So it was an international multi-center hospital-based retrospective cohort study. The study population included women with germline BRCA1, BRCA2 pathological variants and who are diagnosed with stage 1 to 3 invasive breast cancer at 40 years or younger. So what is important out here is breast cancers who are already diagnosed and 40 age or 40 years or lesser. So young patients with existing diagnosis. And this diagnosis that happened between January 2000 to December 2020. Next slide. The exclusion criteria is that patients with missing information on the uptake or timing of the risk reduction mastectomy or the salpingo-oophorectomy were excluded. Patients who underwent a mastectomy or a oophorectomy before breast cancer diagnosis were also excluded, and healthy BRCA carriers were not included, were excluded. The endpoints was primary overall survival, and the secondary endpoints were next slide. Next slide, please. Yeah. So let us come to the analysis method. So Cox proportional hazard model was used to explore the association between the risk-reducing surgery for mastectomy and oophorectomy. The stratification factors included years of breast cancer diagnosis, the region or country where the patients came from, the nodal status, and the DFS, breast cancer-free interval, and all survival endpoints were measured from the time of the breast cancer diagnosis. Next slide. So the overall survival model was adjusted for the development of distant recurrences and development of second primary malignancies. A 3-year landmark analysis was performed to account for potential lead time biases, and a subgroup analysis was conducted, including only patients who were tested for BRCA before or within 6 months of the breast cancer diagnosis. Next slide. So 5,290 patients from 109 centers across 5 continents. You can see there's a massive trial were included in this. The median age at diagnosis was around 35 years. BRCA1 carriers were around 63%. 51% patients had a node negative disease and 45% patients had a hormone receptor positive breast cancer. If you look at the risk reducing procedures, so around 55% patients underwent a risk reducing mastectomy, and the median time from breast cancer diagnosis to a risk reducing mastectomy was around 0.8 years. And for salpingo-oophorectomy, 52% patients underwent a salpingo-oophorectomy, and the median time from breast cancer diagnosis to a salpingo-oophorectomy was around 3 years. The median follow-up after procedures was around 5.5, 5 years in both the arms. Next slide. So if you look at the median follow-up of around 8 years, the overall survival benefit of around 15% was seen. The DFS was around 36%, and the breast cancer-free interval was 33%. If you look at for the mastectomy arm for risk-reducing mastectomy patients, the adjusted hazard ratio was around 0.65, so a 40% risk reduction almost. And this was consistent across BRCA gene types, the age at diagnosis, tumor subtype, size, and nodal status. The reduced risk DFS status was had a adjusted hazard ratio of around 0.58, and the reduced risk of breast cancer free interval is around 0.55, so almost a 50% benefit we can see. Next slide. If you look at the overall survival events also, so if you look at the salpingo-oophorectomy arm, there was definitely a clear overall survival benefit, and it was irrespective of the BRCA status, but the benefit was more pronounced in BRCA1 carriers. Also, if you see in triple negative breast cancers, the adjusted hazard ratio is 0.44 as compared to hormone receptor positive. So again, a clear better benefit in triple negative breast cancers as expected. And the reduced risk of DFS events was around 0.68, and the breast cancer free interval around 0.65. So again, almost a 40% benefit of undergoing a risk reduction surgery. And the results were consistent across sensitivity analysis. Next slide. So to conclude, in this unique international large cohort study of BRCA carriers with prior breast cancer diagnosis at a young age, risk reduction mastectomy and the salpingo-oophorectomy were both associated with significant improvement in overall survival, disease-free survival, and a breast cancer-free interval. And no, these findings, as I said earlier, are critical for improving our counseling skills for young BRCA patients with a breast cancer diagnosis and for managing their future risk as well. I think after this study, even I am more convinced to push patients slightly more in my OPD who are BRCA carriers and who have been my patients in the past. Thank you.
Thank you very much, sir, for an insightful talk. So, progressing with our agenda, let's start with the third talk of the webinar. For this, we have Dr. Pratik Patil, sir, and sir is the consultant Department of Medical Oncology, Jupiter Hospital, Pune. And sir is going to speak on right choices subgroup analysis from phase 2 trial of first line ribociclib plus ET versus combination of chemotherapy in clinically aggressive HR plus class HER2 advanced breast cancer. Over to you, sir.
Yes, can you please share my slides?
Sure, sir.
Hello, good evening, everyone. Thank you so much, Dr. Ashok Vaid, sir, and Samarth Oncology for giving me this opportunity. Today, I'll be speaking on the right choice trial of it, which I'll be focusing more on the subgroup analysis from this phase 2 trial, which was the first line ribo versus ribo with endocrine therapy versus combination chemo in clinically aggressive hormone receptor positive HER2 negative advanced breast cancer. Next, please. Yes. So this was a phase 2 right choice study. So here the researchers have basically enrolled pre and post menopausal patients with no prior systemic therapy for aggressive HR positive HER2 negative advanced breast cancers, and they were randomized 1:1 to receive either ribociclib plus endocrine with goserelin or physician's choice of combination chemotherapy. So as we know that from the data that we have available of the CDK4/6 ribociclib, which was cut off on May 10, 2023, there was a good 9 months benefit that we had seen in this study population as compared with the conventional chemotherapy with a good HR of 0.61. Also, we know that from the exploratory analysis of phase 3 Mona Lisa, there was a much good benefit that was seen in luminal B or HER2 positive group subset of patients, which was dependent upon the PAM50 based intrinsic subtypes. So this basically explores and aims to evaluate the efficacy of this combination in the patients who have a PAM50 based intrinsic subtype testing with available gene signature expression levels. Next, please. So of all the patients that were included in this trial, they had taken the people who were perimenopausal, less than 60 years old, with HR positive, HER2 negative, advanced breast cancers, with no prior endocrine therapy or chemo for the advanced breast cancer. And they were randomized in 1:1 to ribo plus anastrozole or letrozole with goserelin versus the investigator choice combination chemotherapy. Here, the primary endpoint was progression-free survival, whereas the secondary endpoints were TTF, 3 months TFR, ORR, and so on, with safety and efficacy. Next, please. Yes, so out of all the patients that were enrolled, we had total of 49 samples, which were then micro dissected and underwent a gene signature. And they had used basically nanostring encounter BC360 and pan cancer 360 panels. So they defined high and low baseline gene signature expression levels. And based on that, the efficacy was basically evaluated. So you can see that of the 27 samples that were available in the ribociclib arm, 22% were luminal A, 51.9% were luminal B, 22.2 were HR2 enriched, and 3.7% were basal-like subtypes. And of the 22 samples available in the chemotherapy arm, 50% were luminal A, 40.9% luminal B, and 9.1% were HER2 enriched. Uh, Now looking at the PFS, which is the second graph, the median PFS in the ribociclib arm was 32.5 months as compared with the not reached in chemotherapy arm. But for the other subtypes, the median PFS in the ribociclib and chemo were 38 months versus 21.7 in luminal B, which is to be focused here more. And also it was 17.4 months versus 8 months in HER2-enriched subtype. They also had assessed median PFS in the group of patients with luminal B and HER2-enriched subtypes, both of which are known to be linked with a poorer prognosis. So in this also it was 38 months as compared to that of 18.4 months. So we know that luminal B and HER2-enriched subtypes are the two major subtypes that are benefiting with this combination arm. Next, please. Yes, so coming to the main analysis in the subgroup part that we have, here the analysis also include in the ribociclib group with low expression of a lower higher expression of ESR1 protein, where we can see that there was a higher PFS as compared to patients with a low ESR1 expression, which is 38 months as compared to that of 32.5 months. Whereas in the subgroup of the patients where tumor inflammatory signature was seen as per the panel, or T cell panel, or RB1 protein was seen, even in the people who had a RB1 abnormality, they had a higher PFS, which was 38 months as compared to 7.4 months. So these subgroups, these two subgroups, especially the ESR1 protein and RB1, they had a better representation of the ribociclib plus endocrine therapy combination as compared to that of the chemotherapy. So these are the subgroups that are benefiting more with the combination that they had considered in this trial. Next, please. Now, this analysis had also included patients in the ribociclib group with a lower expression of tumor inflammation or immune-related genetic cells, which included tumor inflammatory signature, T cell expressions, B cell expressions, CD45 cells, CD8 T cells, cytotoxic cells, dendritic cells, and all of the cells that we can see in the chart. So as you can see, these patients had a longer median PFS as those with the higher expression of tumor inflammatory signatures, especially the ones with tumor inflammation or immune related genes or cells, which included the T cell expression. So in all of these proteins, the median PFS was longer as compared to the other arms. So these were the ones that were significant as compared to the other. So in the chemotherapy arm, patients with low expression of immune related genes or cells had a shorter median PFS compared with those with a higher expression of tumor inflammatory signatures, which was 15 months as compared to that of not reached. And in the T cell expression, it was 12.8 months as compared to 18.4 months. So there was a comparable and consistent trend in the PFS, which benefit was most for immune related gene or cell expression, and the signatures for low expression levels versus high expression levels. Also, in addition to this, there was a higher PFS benefit for lower gene expression in the patients with ribociclib arm, and higher benefit related to PFS for higher gene expression in the chemotherapy arm. Next, please. Yes. So yeah, we have already discussed this, that depending upon the profiles of low expression levels and high expression levels, again, the ribociclib plus endocrine therapy arm is benefiting more for the immune related gene cells with low expression levels and higher expression levels. So higher PFS was there for low gene expressions, whereas a higher benefit was related to PFS for a higher gene expression in the chemotherapy arm. So this is something that needs to be considered while treating these patients. And if these panels are available to us in our clinical practice, I'm sure the benefit could be much extended to these subset of the patients at least. Next, please. So the investigators' conclusions here was that in the exploratory analysis, although the sample size was very, very small, the ribociclib and endocrine therapy had a much better PFS benefit over combination chemotherapy, which are associated with a poor prognosis, that is luminal B and HER2 enriched. So ribociclib plus endocrine therapy was associated with higher PFS benefit in the patients with high versus low baseline ESR1 expression, more prominent PFS benefit with low expression of tumor inflammatory markers or immune related genes versus those with higher expression. Also, combination chemotherapy was associated with a shorter PFS in the patients with low expression of immune related genes as compared with those with higher expression. So there's a bit of confusion, but I'm sure with more and more panels that we do for our patients, it would be clearer to us. So the investigators concluded that this data serves to generate a hypothesis concerning the predictive value of intrinsic subtypes and immune-related gene expression levels for the benefit of CDK4/6 ribociclib plus endocrine therapy in the patients that are clinically aggressive, HR positive, HER2 negative, advanced breast cancers. So that is all from my side.
Thank you very much, sir, for the educational talk. So carrying on with our agenda, let's move fourth talk of the webinar. For that, we have Dr. Tamojit Chaudhary. Sir is a HOD and senior consultant, Department of Medical Oncology, Meherbai Tata Memorial Hospital, Jamshedpur. Over to you, sir.
Good evening. So hope I am audible clearly. So kindly share the slide deck. And so thanks to organizers, thanks to Ashok Ved sir, and thanks to Summit Life Science for this opportunity. So for the next 10 minutes, I'll be discussing on the Patina study, which is a very landmark trial presented in the last year San Antonio Breast Cancer Symposium in December 2024. So it's basically a randomized open-label phase 3 trial design to evaluate the efficacy and safety of addition of a CDK4/6 inhibitor in the form of palbociclib over and above the standard anti-HER2 therapy and endocrine therapy as a maintenance in triple positive metastatic breast cancer after 6 to 8 cycle of induction chemotherapy plus anti-HER2 agents. Next slide. Yeah, so as of now, as you are aware that there are ample amount of preclinical evidence to suggest that addition of CDK4/6 inhibition is very important for the prevention of development of resistance to both the endocrine therapy as well as the anti-HER2 therapy, particularly true for a triple positive breast cancer. And phase 3 Patina trial was designed based on this basic premise or scientific rationale to evaluate the efficacy and safety of palbociclib added over the standard maintenance therapy, which is the dual anti-HER2 therapy plus endocrine therapy in metastatic triple positive breast cancer, that means HR positive and HER2 positive breast cancer after induction chemotherapy with anti-HER2 agents and standard taxane-based chemotherapy. Next slide. So this is the trial design. Basically, it's an open level design, 1:1 randomization between the two treatment arms. One is the standard arm. After the induction chemotherapy, it is the dual anti-HER2 therapy plus endocrine therapy backbone as a maintenance. And the experimental arm has the same therapy with addition of palbociclib at standard doses. Both the therapies continued until the disease progression or the unacceptable toxicity. If you look on the patient enrollment criteria or inclusion criteria, these are all histologically confirmed metastatic triple positive breast cancer patients. No prior systemic therapy in the setting of advanced metastatic disease were allowed, except the 6 to 8 cycle of induction chemotherapy or induction regimen, which is basically a dual anti-HER2 agent along with standard chemotherapy, which is either taxane or vinorelbine, and all the patients should be completed the standard induction regimen 6 to 8 cycle and should not have any progressive disease. That means after the completion of induction regimen in the metastatic setting, they should have achieved either a CR/PR or stable disease. The primary endpoint was investigator-assessed progression-free survival. Key secondary endpoints were overall response rate, the safety parameters, and the overall survival. Stratification factors are like whether single anti-HER2 agent in the form of trastuzumab used versus a dual anti-HER2 agent, that means pertuzumab has been used or not, prior anti-HER2 therapy received or not in the neoadjuvant or adjuvant setting, response to induction therapy in the metastatic setting, and the type of endocrine therapy used, whether it's a fulvestrant versus an aromatase inhibitor. Next slide. So this is basically the demographic parameters. If we focus on this tabulation, then it's quite obvious that the baseline demographic parameters are pretty well balanced between the experimental arm and the standard control arm. We can see that almost 97% of the patients received dual anti-HER2 agent, that means with trastuzumab and pertuzumab, and only 3% patients received trastuzumab only, that means they don't receive any pertuzumab. 91% patients received aromatase inhibitor as an endocrine therapy backbone, only 9% patients received fulvestrant, and roughly around 70% patients are exposed to anti-HER2 agents either in the neoadjuvant or adjuvant setting. That means roughly around 30% patients having a de novo metastatic disease in this trial. Next slide. So this is a very important Kaplan-Meier curve which suggests that there is a clinically meaningful and statistically significant improvement of the primary endpoint, which was the investigator-assessed progression-free survival with the addition of palbociclib. So the median PFS is 44 months in the palbociclib arm versus 29 months in the standard control arm, with a very impressive hazard ratio of 0.74, and the incremental delta is roughly around 15 months with the addition of palbociclib. What is more interesting in this Kaplan-Meier curve is that the separation of curve favoring the experimental arm started almost immediately after starting the therapy, almost within 2 months of starting the therapy, and the distance or difference between the curves maintained in the longer follow-up. Next. So just like the primary endpoint, the key secondary endpoints in the form of overall response rate and clinical benefit ratio, although both numerically and statistically significant, favoring the palbociclib or the experimental arm. Next slide. The other key secondary endpoints. Next slide. The other key secondary endpoint was overall survival. Obviously, overall survival is an important clinical endpoint for any metastatic breast cancer trial. And for the time being, as per this presentation, up to 52 months of median follow-up at the time of data cutoff, the median overall survival is basically immature. The median is not achieved in any of the treatment arms. So we have to wait for a longer follow-up. Next slide. So regarding toxicity parameters, this is again very important slide which suggests that no new safety signals obtained for palbociclib. If we focus that the grade 4 toxicities are quite comparable between the palbociclib and the control arm, which is roughly around 12% for the palbo arm versus the 9% in the control arm. But interestingly, probably somewhat expected also that grade 2-3 toxicities are higher in the palbociclib arm, particularly in the form of neutropenia, fatigue, stomatitis, and diarrhea. So the good part is that we know that these toxicities are going to happen for a CDK4/6 inhibitor, particularly for palbociclib. These are broadly manageable with standard guidelines. Next slide. So implications in clinical practice. The Patina phase 3 study demonstrated a clinically meaningful improvement in the median progression-free survival, investigator-assessed PFS, which was the primary endpoint of the study, among patients diagnosed with triple positive metastatic breast cancer, with almost 15 months incremental improvement favoring the palbociclib arm with a manageable toxicity. So authors have concluded that palbociclib added to anti-HER2 therapy and endocrine therapy may represent a new standard of care in patients diagnosed with triple positive metastatic breast cancer. Next slide. So these are the authors' conclusions. Next slide. So these were the authors' conclusions that the results of the study reinforce the strong scientific rationale of overcoming the resistance to both anti-HER2 therapy and endocrine therapy by adding CDK4/6 inhibition. The addition of palbo to anti-HER2 and endocrine therapy demonstrated a statistically significant improvement in the investigator-assessed PFS. And palbociclib added to the anti-HER2 and endocrine therapy had a manageable toxicity profile without any new safety signals. So as per my opinion, this is a very landmark study and probably practice-changing study. The only issue is probably 2-3 points are to be discussed. Number one, it's an open-label design where the primary endpoint is an investigator-assessed. We all know what the problems could be for an investigator-assessed primary endpoint in an open-label design. The second thing, the toxicity also broadly manageable, but toxicity is higher in the palbociclib arm, particularly grade 2-3 toxicity. And third is still the OS is immature, so probably we have to wait in the longer follow-up, at least 5 years follow-up, to look for the actually what is the OS trends. Thank you.
Thank you very much, sir, for the detailed talk. Proceeding with our agenda with the fifth talk of the webinar. For that, we have Dr. Ashish Gupta, sir. Sir is the Chairman, Department of Medical Oncology, Lakshmi Narayan Hospital, Jabalpur. Over to you, sir. Sir, will you share your slide or do I need to share?
Lana, I'm sharing. Just a moment. Huh?
Okay, sir.
Is it visible? Is my screen visible?
No,
Hello?
sir. No, sir, it's
Huh?
not visible yet.
I think just a moment. Huh?
Yeah, sure.
This is share.
No, sir.
Just
It
a
is.
moment. Huh?
Yeah,
Just a
sure, sir.
moment.
Yeah.
Screen. I'm actually
Yes, sir.
not able to understand why is it not getting shared. आएगा. It is. I've shared the screen, but it is not.
Sir, maybe your internet is slow.
No,
Or
internet is not slow.
okay. Could you please try once again?
So we can share.
Sorry for the inconvenience. So meanwhile, we are moving forward with our agenda. And for this, we have Dr. Ridu Kumar, and sir is a sir is a consultant Department of Medical Oncology, Magad Cancer Center, Patna. And sir is going to speak on Fuzuloparib with or without Optanib in HER2 metastatic breast cancer patients with germline BRCA1/2 mutations GBCRA/2, a randomized phase 3 trial. Over to you, sir.
Thank you, Dr. Kusi. Kindly share my slides.
Yeah, sure, sir.
Thank you. Good evening, everyone. Good evening, respected Ashok Vaid sir. And I'm very thankful to organizers and Samarth Lab. My topic for presentation is this a phase 3 randomized clinical trial, which compare Fuzuloparib with or without hepatinib in HER2 negative metastatic breast cancer with the germline BRCA mutation. So next slide, please. So this breast cancer with the mutation in BRCA1 or BRCA2 gene exhibit a deficiency in the homologous recombination repair pathway, which compromise the cancer cell repair capacity of DNA. Consequently, these cancer cells are sensitive to PARP inhibitors. So Fuzuloparib, an orally administered PARP inhibitor, demonstrated almost complete inhibition of PARP enzyme and potent anti-tumor activity in preclinical models. And it has approved in China as monotherapy for patients with platinum-sensitive recurrent ovarian cancer and germline BRCA1 or 2 mutations with the BRCA1 or 2 germline mutations who have undergone second-line or above chemotherapy, and as maintenance therapy for patients with platinum-sensitive recurrent ovarian cancer after response to second-line or later line of platinum-based chemotherapy, regardless of BRCA mutational status. The combination of anti-angiogenic agent with PARP inhibitor improved clinical outcome in gynecological cancers. In this study, they have assessed Fuzuloparib with or without hepatinib, a VEGFR2 inhibitor for treating HER2 negative metastatic breast cancer patients with the germline BRCA mutations. So next slide, please. Yeah. So now coming to the study design, this is a randomized open-label multi-center two-part study, phase 3 clinical trial. In part 1, they have demonstrated the safety and tolerability of Fuzuloparib in combination with hepatinib. And here, second part, we present the finding of randomized part 2 study. The eligibility criteria in this study is age group 18 to 75 years patients included, and having with the pathological confirmed HER2 negative breast cancer, having a confirmed mutations in BRCA1 or 2 mutation. So for statistical considerations, they have planned enrollment for 276 patients. Overall type 1 error for a study, one-sided alpha is equal to 0.025 and 198 PFS events per BICR could provide 98% power to detect an hazard ratio of 0.5 for the comparison between Fuzuloparib plus hepatinib and chemotherapy, and 85% power to detect an hazard ratio of 0.60 for comparison between Fuzuloparib and chemotherapy. Interim analysis planned to occur when 139 progression-free survival events per BICR, that is 70% of targeted events occurred, and actual data cutoff date was 15 December 2023. So next slide, please. Next slide. Yeah. So total 254 patients were screened. Out of 51 were excluded. And this is the demographic and baseline characteristic. You can see here that all arms are almost comparable. Median age group is between 47.5 months in standard chemotherapy arm to 49 months in this combination arm, Fuzuloparib plus hepatinib. ECOG performance status 0-1 almost comparable, and similarly BRCA mutations and hormone receptor positivity in all the arms. Next slide, please. So now coming to the outcome, and you can see here that combination arm that is Fuzuloparib plus hepatinib has shown better progression-free survival as compared to a standard chemotherapy arm. And here the median progression-free survival is 11 months versus 3 months in chemotherapy arm, with the hazard ratio of 0.27 with p-value that is very significant, that is less than 0.001. Next slide, please. Yeah, next slide. Here you can see that PFS in monotherapy, that is Fuzuloparib versus standard chemotherapy. This monotherapy arm is also has shown better progression-free survival as compared to the chemotherapy arm. And here you can see the three curve showing the progression-free survival. And this combination arm has shown better progression-free survival, better curve as compared to monotherapy or chemotherapy arm. So next slide, please. Yeah, next slide. And overall survival also. You can see here that overall survival benefit trend was observed favoring Fuzuloparib plus Epatinib. Although 39% patient had crossed over to the other arm. So here the tumor response you can see here overall response is also better in combination arm, that is Fuzuloparib plus Epatinib as compared to monotherapy and standard chemotherapy. And disease control rate is also significantly better in combination arm. And duration of response is 9.8 months as compared to 3.9 months in chemotherapy arm. So this is very clear that this combination of Fuzuloparib plus Epatinib is better as compared to monotherapy or chemotherapy arm. So next slide, please. Next slide. So here the safety data. So most of the you can see here also the treatment related adverse events is also similar between the combination arm and monotherapy and chemotherapy arm. Next slide, please. Yeah, next slide. So most of the adverse events are hematological in combination arms. So now coming to the conclusion, the present study met its primary objective and key secondary objective, that is superiority in BICR assessed progression-free survival. Fuzuloparib plus Epatinib versus standard chemotherapy. Median PFS is 11 months versus 3 months with significant hazard ratio and with significant p-value. Fuzuloparib alone versus standard chemotherapy when they have compared, the median PFS is 6.7 months versus 3 months. And this combination when compared with the monotherapy arm, again the hazard ratio is 0.6 and p-value significant. So Fuzuloparib plus Epatinib or alone demonstrated a trend toward improved overall survival as compared to chemotherapy, despite a crossover rate of 39.4% from chemotherapy to Fuzuloparib. And Fuzuloparib plus Epatinib or alone showed an enhanced tumor response than standard chemotherapy. The profile and severity of toxicity were consistent with previous report of Fuzuloparib and Epatinib. And taken together, the author concluded that our findings support the use of Fuzuloparib plus Epatinib or Fuzuloparib alone for HER2 negative metastatic breast cancer with the germline BRCA mutations. So thank you. Yeah, thank you.
Thank you very much, sir, for the detailed talk. So, Dr. Ashish Gupta, sir, please continue.
Good evening, everyone. At the outset, I'm very thankful to Ashok Bhatt sir and the team for giving the opportunity to speak on this topic. It is a very important trial. The trial is Olympia. It is a phase 3 multi-center randomized placebo-controlled trial of the use of adjuvant olaparib in adjuvant setting after neoadjuvant chemotherapy in the patients who have germline BRCA1 and BRCA2 pathogenic variants and high-risk HER2 negative primary breast cancer. And it is basically is a longer term follow-up. Next slide. Next slide. Yeah. So basically, inhibition of PARP enzyme lead to synthetic lethality in the cells which are deficient in homologous recombination repair, and those with BRCA1 and BRCA2 mutation. Now, BRCA1 and BRCA2 mutations, we all know that germline mutations they pose the patients for development of breast cancer. Next slide. Olaparib is a PARP inhibitor, and this is the study rationale for the use of olaparib in the adjuvant setting. Next slide, please. So this the overview of the trial is this is the trial identifier, and it is a randomized controlled randomized trial. It compared 1 year of adjuvant olaparib versus placebo. 1836 patients with pathogenic and likely pathogenic variants of germline BRCA1 and BRCA2 mutations were taken, and then they were randomized on 1:1 basis on placebo and olaparib. Next slide. So this was the study design which we have already discussed, and these patients were randomized on olaparib 300 milligram BID for 1 year in the adjuvant setting or placebo BID for 1 year. The total number of patients on olaparib arm were 921 and the patients on placebo arm were 915. The primary endpoint for the interim first analysis was IDFS, and the secondary endpoints was distant DFS, overall survival, safety, and the occurrence of other BRCA2, other malignancies which are related to BRCA2. Next slide, please. So this is again the same trial scheme. Next slide. The patients were very well matched on the baseline characteristics of median age, BRCA mutation, prior neoadjuvant chemotherapy or adjuvant chemotherapy taken, anti-menopausal. So they were ideally they were fairly well matched in all the characteristics. Next slide, please. Next slide. Next slide. These are all the patient characteristics. We won't go into the details because time is very limited. Next slide, please. So this was the first interim analysis, which was called interim analysis 1, and it showed this trial started in 2017. The first interim analysis was done in 2020. The first interim analysis showed that it had a statistically significant improvement in invasive disease-free survival, that is IDFS, and distant disease-free survival, that is DDFS. The first analysis showed a significant improvement in IDFS and DDFS, and that was statistically significant. Next slide, please. So after the interim analysis 1, these were the conclusions of Olympia interim analysis 1, which was done after a median follow-up of 3.5 years, and it showed a significantly improved IDSS and distant disease-free survival. And this treatment effect was consistent without any evidence of significant heterogeneity across major subgroups, including BRCA1, BRCA2, hormone receptor positive, and triple negative cancer subgroups. So we met the first primary endpoint after interim 1 analysis. Next slide, please. The second interim analysis, that is IA2, it demonstrated a statistically significant improvement in overall survival also, and that is very important. The interim analysis 1 did not show overall survival advantage, whereas interim analysis 2 showed a statistically significant improvement in overall survival. And second, it maintained the improvements which we observed in IA1 in respect to IDFS and DDFS. The rates were consistent again across all the subgroups, irrespective of the hormone receptor status, prior platinum administration, timing of prior chemotherapy, and type of germline mutation. And then in the interim analysis 2, we also observed that there was no excess increase in other malignancies related to BRCA. Next slide. Next slide. So this is the Kaplan-Meier of second overall interim analysis 2 of the 3-year overall survival, wherein it showed a significant 3.8% advantage in the overall survival. Next slide. This is the subgroup analysis of overall survival in IIT, which showed the hazard ratio to be in favor of olaparib arm across all the subgroups. Next slide, please. This is the analysis, the Kaplan-Meier analysis of IDFS in the IA2, and it showed a difference of, after 3 years, it showed a difference of 8.8% in 3-year IDFS rate and 7.3% difference in the 4-year IDFS rate. It was done after 48 years, 4 years of analysis. Next slide, please. And this analysis of IDFS, it showed, next slide, next slide. It showed the hazard ratio showed improvement and across all the subgroups for olaparib. It favored olaparib. Next slide, please. This is the analysis of DDFS, that is distant disease-free survival. In again showed after 3 years, a DDFS difference was 7%, and after 4 years, the DDFS rate, the difference was 7.4%, with both of which were statistically significant. Next slide. And the next slide. Hazard ratio showed in the favor of olaparib arm across all subgroups. And there was no major change in the adverse event profile when it was compared to placebo arm in the interim analysis 2. Next slide, please. Next slide. This is again the same adverse event cycle, which was not very, very different. Now come the third interim analysis that was done after 6.1 years of follow-up. And the reports of the results of the third pre-specified interim analysis with updated data were published in this. Next slide. I3 results are very good. With longer follow-up, the benefits in overall in olaparib arm in the respect to IDFS, in the respect to DDFS, and in the respect of overall survival were maintained in spite of everything. For the IDFS, the 6-year IDFS the 6-year IDFS was 79.6% on olaparib arm versus 70.3% on the placebo arm, with a difference of 9.4%, which increased as compared to IA2 results. Similarly, for DDFS, the difference was 7.8%, which significantly improved over a period of time as compared to IA2 results. Next slide, please. So basically, IDFS, DDFS, and then the third was overall survival, which after 6 years of follow-up showed a 4.4% difference in favor of olaparib arm as compared to the placebo arm. So overall, the olaparib benefit was consistent across all the key subgroups, including patients with high-risk hormone receptor positive disease. Next slide. Then IA3 results also showed that there were fewer BRCA-associated cancers. They were reported on olaparib arm compared to placebo arm. In respect to contralateral invasive breast cancer, contralateral non-invasive breast cancer, ovarian cancer, new primary ovarian cancer, new primary fallopian tube cancers, all the cancers which are BRCA associated, they were significantly less in the olaparib arm as compared to placebo arm. Next slide, please. So the conclusions, after IA3, after 6.1 years of median follow-up, 1 year of adjuvant olaparib arm after neoadjuvant chemotherapy continues to demonstrate meaningful improvements in IDFS, DDFS on overall survival in patients with germline BRCA pathogenic variants and high-risk HER2-negative primary breast cancer, including all subgroups, and with acceptable toxicity, with no evidence of increased risk of MDS or acute myeloid leukemia. And these data continue to highlight the importance of germline BRCA pathogenic variant testing in high-risk HER2-negative primary breast cancer. And this is the third interim analysis. This analysis will continue till 2030. And I'm very sure these results, the Kaplan-Meier graphs would significantly widen by the time the final analysis of this trial is done. Next slide. Thank you very much. With this, I end the discussion of Olympia. And I'm very thankful to Ashok Vaid sir and the Samarth team for inviting us on this platform. Thanks to all of you for patient listening. Thank you.
Thank you very much, sir, for the instructive talk. And lastly, we have panel discussion on role PARP inhibitors in metastatic triple negative breast cancer. For this, we have our moderator, Dr. Shuman Mittal ma'am, and she is a consultant, Department of Medical Oncology, Mittal Hospital, Raipur. Ma'am, I would like you to do the needful and introduce her panel members.
Yeah, so thank you, Dr. Vaid sir and Samarth Pharma, alumni, for organizing particular talk and this panel discussion. This is very important. Hello, can you everybody hear me?
Yes, ma'am.
Yeah. So this is a very important discussion, and I think we as a medical oncologist, we do face a lot of problems while we are dealing with triple negative breast cancer, particularly when they are metastatic, and a lot of the patients who, even if we diagnose them early, they tend to metastasize. So today we'll be talking about panel discussion of the role of PARP inhibitor in metastatic triple negative breast cancer, and I would like to introduce my panelists. So are all of them available? Dr. Ankit Jain, Dr. Kausal Patel, Dr. Poonam Patil, and Dr. Vandana Joshi. So, and Dr. Hani Parikh, Dr. V. Arumugan. Anyone else?
Yeah, we are there.
And Dr. Jay Chandran and Dr. Vipul. So everyone is available for the panel?
Yes.
Okay, so can you share the slides, please? So while we are waiting for slides to get uploaded from the host site, as a medical oncologist, like in your practice, how much is the percentage of triple negative breast cancer which we see in our practice? So anyone?
Yeah,
I'll say
around
20.
25% to 30% patients are the triple negative breast cancer.
Do you feel that we have more triple negative breast cancers than what we see in the literature or in the Western countries?
Yes, we do
Yes.
have more numbers.
So I think that is one thing in the subcontinent, that is what we feel, that we have much more incidence of triple negative breast
Triple
cancer,
negative.
and that to you in younger population.
Younger
Right?
populations.
That,
So
in general,
premenopausal patients, almost around 30% patients are triple negative in South India.
so maybe or even more. I mean, what I see in my practice, more than 50% of the breast cancer are premenopausal. So
Yeah.
that is much younger population as compared to Western population, what we see. So we'll be discussing about the role of PARP inhibitors in metastatic triple negative, and what I think why it is very important, because many of these triple negative breast cancers, by the time we diagnose them, they are metastatic, and even if they we diagnose them, stage 2, stage 3, they're very high chance that in future, they recur with the metastatic disease in future. So, Dr. Ankit, are you available? Dr. Poonam. So anyone, I mean, so what is like chances of your patients which you see in early stage 1, 2, or 3 disease, they come with metastatic disease later on.
So stage 3 and all, I have seen almost like 50% patients will come back. Stage 1 and 2, I have seen less. But compared to hormone positive and HER2 new positive, triple negative breast cancers, be it stage 1, 2, 3, they do recur. They do recur much compared to other subtypes of breast cancer.
Yeah, anyone else? When somebody has some other opinion or other experience about triple negative breast cancers, stage 1, 2, 3 disease, which they present to us initially and later on, they are metastatic on follow-up.
Even I have a similar experience as Dr. Avinash said. Triple negative breast cancer is at a high risk variety, even if it is stage 1, 2, or 3. Even I have seen some cases of as early as like 1 centimeter, 1.5 centimeter tumors, node negative tumors, recurring back within a 1 or 2 years of time, especially in younger population. So
Yes,
triple negative itself is a high risk variety. I must say, as he pointed out, stage 2, stage 3 disease, almost 50% chances of recurrence. Even in stage 1 disease, there are almost 10-20% chances of recurrence. And usually this recurrence occurs very early, like as soon as they finish adjuvant therapy within a 1 year or 2 years time, they tend to recur back either at the local site or the metastatic disease. In the other way around, if the patient of triple negative cancer passes 2-3 years periods, then I'm much comfortable that like the likelihood of recurrences are being less once that 2-3 year time goes by.
Triple
I
paradox.
I think that's very much right, because even our earlier patients, so I have a long practice now of 16 years. So initially trastuzumab was not available so frequently. So there were so many patients who were not receiving even trastuzumab. Now they are getting it through even Ayushman. So even they never used, like, frequency of their recurrence, HER2 positive recurrence, even without receiving trastuzumab, was much less as compared to triple negative. So even early breast cancer, sometimes stage 1, as you said, that they tend to recur. So now we'll be talking about the role of PARP inhibitors in triple negative breast cancer. So this is in general, this is how we investigate and how we treat triple negative breast cancer. So any patient, so what are the essential investigations? So are we doing all these investigations for all the patients? So like PDL1, BRCA, in adjuvant setting, or we are doing in metastatic setting?
BRCA and PDL1, both we are doing in adjuvant as well as metastatic setting. PDL1, though in adjuvant setting, the trial says that it is independent of that, the benefit, the DFS benefit, and but what in my experience is that even in adjuvant setting, if PDL1 is low, the outcome is not that great. Rather than when PDL1 is high, it is better. And with germline BRCA positivity, it is beneficial in both setting, whether it's adjuvant or metastatic.
So, like, in how many percentage of your patient you do see TNBC coming as germline, and like practical experience, and how many percentage of them are having PDL1 CPS more than 10, and how many percentage of patients are having germline BRCA and other mutations, which can be targeted with PARP?
Germline, I have seen almost around 20 to 30% patients it will come positive. PDL1, I do not exactly remember. Like you are asking whether with germline, whether other
In
mutations
general,
are present or not, right?
so
So PDL1, in few patients I have seen like more than 10%, 20%, but in many patients I have seen like 1% or less than 1%, 0%. So the PDL1 positivity in my patient is not that good as compared to germline BRCA positivity.
So this is in general how we treat metastatic patients. So for all the investigations, I think all of us are doing now PDL1, germline, BRCA, And based on this, there are three categories we can divide. So if somebody is PD-L1 positive, so those patients will go for IO, that is atezolizumab with nab-paclitaxel or pembro with chemotherapy. Or if patient is germline BRCA positive, then there are generally two options. One is to go ahead with the platinum-based chemotherapy, and other is to go ahead with the PARP inhibitors. So, what are the in general practice all of us are doing? So, what is the preferred? So, if we have diagnosed now, we have a patient who is 35-year-old metastatic and germline mutation BRCA is positive, and affordability is not an issue. So, what is our preferred treatment of choice? It's a chemo, platinum-based, or it's a PARP inhibitor? First line.
So in our practice, we are doing chemo with platinum-based chemotherapy. So we are not going with the PARP inhibitor upfront.
Okay, so any reason for that? I mean, why we are choosing one option over another?
Yeah, even though the acceptance is a big issue in our side, so that is the major reason for the they are accepting for the chemotherapy as a first line, and after that only they are willing for the PARP inhibitor. Maintenance PARP inhibitor we are doing.
Any other opinion or any other way of practice?
My practice also same only. We do give chemotherapy in first line, and if the patient progresses, then only we are going to give this Olaparib. Regarding this PDL1 positivity, it's written Atezo plus Napacli has this indication has been withdrawn, right? Like we are using only Pembro if CPS is more than 10 in metastatic TNBC. Are we using Atezo Napacli right now?
Very nice. I think most of are using Pembro.
Yeah.
And so, in my practice, again, even if sometimes, we want to use PARP, so, many times economy is the issue. So, platinum-based chemotherapies comes much cheaper. And sometimes patients feel that giving injectable is going to give them more benefits. So, that is how also there is some bias. So, we'll see
I
that
think
further.
symptoms of disease burden also is important. I think
That is
baseline patients
important.
do have greater disease burden. I think chemo helps in better early
So that
recovery.
is what I prefer if somebody has more burden, more symptomatic. So generally it is a tendency. So any other opinion based on the crisis or tumor burden? Any choice of like preferred drug? So chemo, platinum based or PARP?
Even my practice is like I do prefer using platinum-based chemotherapy for triple-negative breast cancers, and the reason behind it, like we do have a lot of experience of using chemotherapy, and we know it's a chemosensitive disease. Although the responses are not that long-lasting as compared to other the breast cancers. But like using PARP inhibitor, one thing is like giving 300 mg BD dose is, I think, more toxic than giving chemotherapy itself.
I think all of us totally agree because our patients do not tolerate that much dose that has been not standard in a Western world. So what platinum you are using? I mean, carbo you prefer or basis?
The carboplatin is a preferred choice for the simple reason, the less toxicity as compared to cisplatin.
Combination of
taxane and a carboplatin, yes.
Taxane.
Taxane and carbo, yes.
So, so that is in general we are. So I think that most of us are using paclitaxel carboplatin in a first line metastatic setting. Though if given a choice or less tumor burden, we can even prefer PARP inhibitors. So we will see that it's a significant role in a first line setting. So though we are traditionally, we are most comfortable using paclitaxel in metastatic TNBC. Right? So if we saw the biological rationale of using PARP, so TNBC has higher frequency of germline variant of homologous. So HRR that are targetable by PARP. Germline mutations are seen in, that is a BRCA1 fusing is seen in observed in almost 10% of the TNBCs. And BRCA1 mutated breast cancer usually display a basal cell type or triple negative phenotype. So other than BRCA, there are other variants also which might respond to PARP inhibitors like PAL-B. Next slide, please.
I think there is a recent trial also in which it has been shown that PAL-B2 mutation Olaparib does help. I think it was recently came.
There are trials and then other trials are going on. So we will see that later in the discussion if we can even not only the mutation but even further targets. If we can target with the PARP, it might be helpful. So
Okay.
next slide, please. Next slide, please. So this was an important studies, two important studies, that was the Olympia and BRCA, which was done for metastatic triple negative breast cancer. So almost similar results in both the studies with some differences. So in Olympiad, so it was either it is a triple negative or ER positive HER2 negative diseases. In most of these patients had BRCA mutation positive. They had received either anthracycline or 2 or less than 2 prior chemotherapy. HR positive disease that has progressed after one or one more line of endocrine therapy, or there is no, if there is a prior platinum use, then disease should not have progressed while receiving platinum, because we understand this platinum, most of these TNBCs are, most of the BRCA diseases are positives are very much platinum sensitive. As compared to that, it has involved more patients, so it has even used patient without prior chemotherapy or lesser number of chemotherapy, TNBC, or patient who had HR positive but HER2 negative, or patient had history of CNS met. So they were for Olympiad, it was randomized in 2:2 ratio. In one arm, there was Olaparib 200 milligram BD, another arm chemotherapy of physician's choice. We need to remember that these patients are already receiving 2 or more line of, at least 2 line of chemotherapy. So most probably these patients had already received anthra or the platinum-based chemotherapy. In BRCA, it was again randomized into 2:1 ratio. One side they had received Fuzuloparib, and other side has received treatment or chemotherapy choice by physician. Next slide, please. So, if we see this previous slide, please. So, previous slide, please. So, if we see PARP inhibitors in metastatic TNBC, so we do see benefit in terms of progression-free survival as compared to chemotherapy, though this benefits tend to decrease over a period of time in both the studies, Olympiad and BRCA. Next slide, please. One very important thing which we all consider about the quality of life. So this study shows that these patients who received PARP inhibitor, they had better quality of life in both the studies. The patient who received Olaparib and the patient who received Fuzuloparib. So what is the opinion of panelists about the quality life of like? Do you agree? Do all of us agree that PARP inhibitors gives better quality life as compared to chemotherapy in our setting?
So I think neuropathy is a problem. Like taxanes we are using in particularly breast cancer, I have seen after giving like 3-4 cycles, they will have complaint. I think that complaint might not be there with Olaparib, but Olaparib has its own side effect like fatigue, anemia. So I don't think, in my experience, I think it's almost equal or equivalent, the quality of life.
Yeah, any other opinion? What are others' experience?
Yeah, the tolerability of Olaparib with the actual dose means 300 mg BD is a little bit tough to manage than the chemotherapy. Chemotherapy, the first week only the patient's quality of life will be a little bit low. Otherwise, next 2 weeks they will improve and they will do better. So, as of my experience, they are tolerating well with chemotherapy than the Olaparib.
So I think that is even my experience, similar experience what you all of us share. That standard dose 300 milligram Olaparib, most of our patients will be much worse and worse quality of life as compared to chemo standard Paclicar what we are giving to them.
Yeah.
So, but anyway, so there was a study showing that PARP inhibitor had better quality of life. Next slide, please. Next slide. So, but if we see, though the patient had a benefit in terms of progression-free survival, but a very important thing which we always look up to is overall survival. So there was no benefit in terms of overall survival, whether patient was started with chemotherapy or patient was given a PARP inhibitor. So next slide, please. But a very important subgroup analysis that the patient who received PARP inhibitors as in a first line setting rather than second line, third line setting, they have definite better survival. So if we see the curves, they are well separating. So if we see the first graph, so the patient who had received in the first line, they have better survival. That is the average survival of median overall survival with Olaparib was 22.6 months as compared to 47.7 months with physician choice chemotherapy. But in the patient who had already received prior chemotherapy, the overall survival was not very different. So, I mean, I think we have at least an idea that if we can give PARP inhibitors in first line setting, probably they will have better overall survival. So, but our problem is intolerance or lesser tolerance with the PARP inhibitors. So, I would like to ask the opinion of others at what doses we are starting with PARP inhibitors. Are we going, starting with the low dose and stepping up, or we are like more in favor of step down?
So this is my practice. I am started with low dose, so means 150 mg BD, and then I have to escalate the dose depending upon the tolerability. That may be
And
the best. Yeah.
Oh, I start with 300 milligram BD only. Depending upon the tolerance, I do change the drug level because see all the trials whatever been done in out maybe in the not representing our population, but still 300 milligram BD they have used. So if there is a tolerability, I have seen few patients they tolerate 300 BD also. So why not to give them that benefit? At least few patients will tolerate. If they are not tolerating, we'll
So,
decrease.
are we, I mean, there's no guideline, but are practically doing something depending upon the age or physical condition of the patient? Like for a younger patient,
Performance
we are
status. Yes.
starting with the step down, ladder, and for older patient, like, so is there are such things we are doing? Because what I tend to do is for older patients, I tend to start with the lower dose. But if somebody is 35, 40, so I tend to start with the higher dose, and if they are not tolerating, then stepping it down.
Okay. Good.
So next slide, please. So, so now there are next generation selective PARP1 selective inhibitors are coming. So one this drug, Fuzuloparib. So this drug has shown Fuzuloparib basically a first in class quoted new generation PARP inhibitor with high selectivity for PARP1, and it has got wide therapeutic index, superior PK/PD properties and efficacy compared to our currently approved PARP inhibitors. And it has a favorable safety profile and a low rate of dose reduction as compared to approved PARP inhibitors which we are facing. So maybe when this drug is approved, maybe we'll have a better response and better tolerability even in our patients. So next slide, please. So these are the different PARP inhibitors which are under evaluation and different phases of trials for TNBC, and Fuzuloparib is already in phase 3, but others are still in phase 1 trial. Next slide, please.
Dr. Suman, sorry to interrupt here, but we would be now reaching the deadline of our allotted time. If we could wrap up in the next about 5 minutes.
Yeah, so we try to wrap up. Next slide, please. So this is another study where PARP inhibitors with immune checkpoints were used. So initially, it was randomized between chemotherapy and pembro. Induction was given with chemotherapy and pembro, and then for maintenance post-induction it was randomized maintenance of on one arm pembro with olaparib and another arm there was the pembro with chemotherapy. Next slide, please. And this so next slide, please. So in this we see that PARP inhibitors, there is not much difference even if we are adding PARP inhibitor to IO in post-induction. Next slide, please. So basically, these are the other trial, so once this study is like, once patient progresses after PARP, there is not much benefit of adding platinum-based chemotherapy. So there are other drugs on which trials are already going on, but right now, if somebody progresses on PARP, we should be encouraging to them for clinical trials. So next slide, please. So this is the PARP inhibitors and metastatic concluding slide. We have certain challenges and perspective. So understanding mechanism of PARP resistance and developing novel agents to overcome the resistance. Developing predictive marker beyond BRCA1 and BRCA2 that includes functional biomarkers so that we can target even if they are BRCA negative. BRCA is, and evaluating novel combination with PARP1 selective inhibitors which are supposed to be more tolerated. Thank you. Thank you, panelists, for a great discussion. Thank you, Dr. Wetzel, for giving me the opportunity for moderating this session. And sir, I would like to hear your...
Thank you so much.
Thank you.
Suman. Any last minute comments by the panelists? I could hear someone saying something. Okay. So thank you, Dr. Suman, for that wonderful moderation. And I'm indeed very privileged and to having seen the proceedings and the wonderful presentations, so much of academic activity in the last 1.5 hours. Thank you, all faculty, all panelists, moderators. Thank you, Mice Ideas, Rajesh, Priyanshi, and Dr. Khushi. We had 227 live audience on this program, which is a very credible number. And thank you, Samarth Pharma, Om, for the support month on month, and Indian Oncology Foundation for laying down this platform. We hope to come back again with another program, and let me announce it to everybody who's on the program at the moment that there is an Indian Cooperative Network meeting in Delhi. That is an in-person meeting on the 9th, 10th, and 11th of May. And that's a multidisciplinary meeting which would have hematology as well as meta-oncology as well as solid tumors. And do register. The program would be live very soon, and the mailers would come out very soon as well. Thank you so much. Good night. Stay safe. Take care.
Thank you, sir.
Good night and thank you, everyone.
Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you.